Hi guys, welcome back to the channel. So we have started with the treatment and management part of ameloblastoma. We have deal with the conservative treatment that we can use enucleation, marsupialization for conservative therapy, but with chemical cauterization. Chemical cauterization means the use of modified cornoid solution, and we can do this with peripheral ostectomy. But enucleation or conservative treatment had recurrence rate, it should not be done. It mainly done in unicystic ameloblastoma or mural ameloblastoma which have not invaded to the connective tissue. Okay, so we can go for conservative treatment with that, but otherwise we have to do radical treatment or curative treatment. Okay, let's start today class. We'll be discussing about the brief in maxillary management of ameloblastoma. Let's start. So, type of pathology, it is benign. Extent of involvement, it can involve sinus, pterygoids or infratemporal fossa. Site of the tumor, if anterior, only 9% occur in this region. It is a less aggressive treatment compared to mandible. Partial or total compared to the posterior. Partial or total maxillectomy result in significant deformity. Okay, posterior 47% in molar region, more dangerous than mandibular ameloblastoma. Their cortical bone easy spread and not well confined. ठीक है, because there is a thin cortical bone or we can say cancellous bone is present, so easy spread of tumor is there and they are not well confined, so it is more dangerous than mandibular ameloblastoma. Okay, now excision options are possible. For example, marsupialization of oral cavity or maxillary sinus if present in these two areas, enucleation and curettage, en bloc resection, low level or high level maxillectomy. What are the axis incision for maxillary tumor? Transoral axis, Weber-Ferguson incision, anterior tumor, mandibulectomy. Provide excellent access for primary tumors, especially when access required for pterygoids and infratemporal fossa. What are the mode of repairment in maxilla? Same, primary closure or packing cavity to allow healing by secondary intention with a healing plate. Obturator is given. Local flap, example temporalis, or free flap reconstruction. Okay, this is the brief. We have dealt about brief in mandible, the management, the type of pathology, extent of involvement, site of tumor, and same access, incision, repair options, and same goes for maxilla. Now coming to curative therapy, that is radical therapy or surgical treatment. Surgical treatment and reconstruction. Resection principle require resection of 1 to 1.5 centimeter bony margin, that is peripheral resection. Okay, resection required resection of 1 to 1.5 centimeter of bony margin with and one uninvolved anatomic barrier. Resection should be followed with one uninvolved anatomic barrier. Frozen section, discontinuity tumor, free margin. Transoral, transcutaneous approach can be planned. Okay, we have seen this, that what approach we can go for in access incision for mandible. Okay, for stabilization of mandible, rigid plate fixation is done. Plate that is used is titanium plate is used. Thickness 2.4 mm or 2.7 mm thick. Okay, what all procedure can be done in mandible for tumor? It's alveolectomy, marginal mandibulectomy, segmental resection, hemimandibulectomy, partial, total or subtotal mandibulectomy to be performed. Okay, these all are the treatment option, or rather to say surgical treatment option for mandible. This is for reconstruction. We can go for recon plate. So plate used is of titanium plate and thickness is this, and rest all we have dealt in last class. Okay, so next class we'll be starting with some of the procedure for mandible treatment. Okay, till then, like, share, subscribe and comment. Bye.